Good afternoon, everyone. My name is Monica Valdez-Lupi, and I'm the Chief Program Officer of the Health Systems Transformation Team at the Association of State and Territorial Health Officials, ASTHO. I'd like to welcome you to today's webinar from the New England Regional Health Equity Council. Before we begin, however, I'd like to thank the Federal Office of Minority Health for their support for this webinar. We've worked very closely with the team at OMH and several regional health equity councils to organize these webinars. In this particular webinar today, we'll describe strategies, resources, and tools used to promote equity through community health worker initiatives throughout the New England region. As many of you know on the call, there are different definitions for community health workers, or CHWs. But one definition that we're using for the purposes of today's presentations is that a CHW has been defined as a frontline public health worker who is a trusted member of and or has an unusually close understanding of the communities that they serve. It's this trusting relationship that enables the CHW to serve as a liaison between health and social services and the community to facilitate access to services and improve the quality and cultural competence of service delivery. CHW's role facilitates addressing and ultimately reducing health disparities and helping communities achieve health equity. I'd also like to mention the resources that you can find at our ASTHO website. On this link, you'll find resources on federal Medicare and Medicaid rulings, legislative tracking, and state efforts that facilitate and promote community health worker programs. Now for some housekeeping points and logistics. If you have a question during this webinar, please post your question into the chat box, which you'll see at the lower left-hand corner of your screen at any time during the webinar. These questions will be answered during the Q&A at the end of today's presentation. We'll also open up the line for live questions from webinar participants. And finally, at the end of the webinar, you'll be directed to an evaluation survey. Please take a few minutes to complete this survey because we use this information and any feedback that we get on our webinars to help us at ASTHO design future webinars. Before starting with the presentation, we're actually going to start with a polling question. And we have two polling questions that we've included in the webinar. The first polling question is as follows, and this is to try to get a sense of our participants who are on the call and your familiarity and work with CHWs in this topic. So the first polling question you should see on your screen, and the question reads, are community health workers an integral part of your organization's strategy to address health disparities? Please click on the right answer for you and the organization where you work, and we're going to go to the next slide to see the results. Next slide. Take a few minutes. It's calculating people's responses. Okay. Are we able to move to the next slide with the results of that poll?
Yeah. Yes.
Okay. I think my screen might be frozen, so I'm going to go ahead. From what I see in the response tab on the webinar, this is not a surprise that the overwhelming majority of the participants on the call agree that CHWs play an integral role in their organization's strategy to address health disparities. So we'll move on to our speakers. We have several speakers on the call, and I'll just quickly walk over their bios for everyone on the webinar. We're joined today by Durrell Fox. Many of you know Durrell. He's a community health worker in Massachusetts with over 24 years of experience, starting with his work at Children's Hospital Boston and Martha Elliott Health Center, serving youth living with HIV and coordinating peer education and community outreach programs. Durrell has been involved extensively and actively in local, regional, and national initiatives and movements related to CHWs, HIV/AIDS, and health equity. For 15 years, he's been the Minority AIDS Initiative Project Director for the New England AIDS Education and Training Center at UMASS Medical School, where he coordinates HIV-related training and technical assistance for providers in the Region 1 states who are serving people living with HIV. He's been a member of the New England RHEC since it started in 2011, and prior to that was a member of the New England Regional Minority Health Committee for 10 years. We're also joined by Lisa Renee Holderby-Fox. Ms. Holderby-Fox is a CHW workforce consultant, and her clients have included the Delmarva Foundation for Medical Care, Mariposa Community Health Center, Northeastern University, and Central Massachusetts Area Health Education Center, AHEC. Her past work includes overseeing the health equity activities at the Community Catalyst, and she was also founding executive director of MACHWA, or the Massachusetts Association of Community Health Workers. Lisa serves as a content expert at local and national initiatives and has presented extensively in conferences in the U.S. and Canada. She's worked to promote improved health in Massachusetts and nationally for almost 25 years. She's appointed Commissioner to the National Healthcare Workforce Commission, which was created as part of the Affordable Care Act. Following Lisa, we'll have Jeffrey Wilkinson, who is now serving as a clinical associate professor at the Boston University School of Social Work, where he specializes in work with communities and organizations. Jeff will also be teaching health politics and policy for the BU School of Public Health. From 2007 until just last month, he served as a senior manager of the Massachusetts Department of Public Health, overseeing their policy and planning efforts. He was founding chair of the Massachusetts Board of Certification of Community Health Workers and has been involved in CHW policy and workforce development since 2002. Prior to joining state government, he worked for 15 years overseeing the Massachusetts affiliates of the American Public Health Association and the National Council of Senior Citizens. Following Jeff's remarks, we'll be wrapping up the webinar with Barbara Ginley. Barbara Ginley is the project director, and she received her BA in English and Art History from Bates College in Lewiston, Maine, and went on to receive her MPH from UNC Chapel Hill. She served as MMHP's executive director from 2000 to 2013. And during that time, Barbara directed Maine's statewide primary care program for migrant and seasonal farm workers. Barbara's a keen eye for the big picture, and her confidence in the diverse strengths of our staff allowed MMHP to meet the evolving needs of their patients, despite the size of their organization. Since the fall of 2014, Barbara has taken on a new role within the organization as the project director for the state's Community Health Worker Initiative. This project builds on their expertise in working with camp health workers and promotores, and will offer communities the tools and skills to navigate the healthcare system. And so with those introductions, I'm going to hand off the slides now to our colleague, Durrell Fox. Durrell?
Hello, everybody. I hope you can hear me well. I want to thank ASTHO and the Office of Minority Health for their partnership on this webinar, and welcome all of you from the New England, also known as Region 1 Health Equity Council. We all felt it was important to host a call on this topic and to provide regional perspective, as well as to look at how some states in this region contribute to our regional CHW movement. I want to give you some background on the RHECs, which are part of the National Partnership for Action to Eliminate Health Disparities. The vision of a Healthy America brought together thousands of leaders to develop the National Partnership for Action to Eliminate Health Disparities. Efforts to end health disparities are inherently comprehensive, community and systems change efforts. The NPA is about change, where there should be change, who should affect the change, and the strategies that can be cohesively applied to implement the change. The NPA is one of the first national multi-sector community partnership-driven efforts on behalf of health equity. It was sponsored by the U.S. Department of Health and Human Services through its Office of Minority Health. There's been a sequence of activities that included regional meetings. Community and stakeholder leaders throughout the country came together during summits. There was also national public commentary period and numerous levels of review and analysis to develop the NPA. The RHECs, or the Regional Health Equity Councils, are a key element of the National Partnership for Action. RHECs are comprised of practitioners from various sectors, including healthcare, education, transportation, technology, and business. The RHECs really are about working to mobilize regional action around common issues related to health equity and specific to states in that region, leverage federal, regional, state, and local resources. They work to infuse the goals of the NPA into policies and practices on the ground. Also, we look to support and enhance state and community efforts, as well as one of the critical points is sharing stories, lessons learned, successes from across the country, which happens through meetings and forums that bring RHEC members and leadership together. Here's just a quick snapshot of the regional RHECs, and they fall in line with the HHS regions, and in New England, we cover the 6 states in New England for Region 1. Okay. Next up, I just really wanted to give people a quick snapshot of the National Partnership for Action common priorities. In the fall of 2011, RHECs from across the country held their inaugural meetings. Each RHEC discussed the goals of the NPA. I'll show you the full list of goals later, and identified priorities in their region. Common priorities that emerged from the RHECs are shown on this slide. The RHECs build on these priority areas to develop implementation strategies. In New England, one of our priority areas was community health workers. I just want to share with you the mission and vision of our Regional Health Equity Council in New England, which simply stated our mission is to achieve health equity through cross-sector integration of actions and resources to optimize health for all where they live, work, and play, and also simply stated our vision is a New England free of health inequities. Soon after our inaugural RHEC meeting, we decided that one of our priority areas would be related to CHWs, as we saw them as part of the solution for achieving health equity. And please note that we used the term part of the solution, which also was used in a recent Health Affairs article that some of us who are presenting co-authored, but we really want to illustrate how CHWs are just a part or a piece of the solution, but much more is needed to achieve true health equity, including addressing the social determinants of health, or the determinants of health, if you may, the root causes of inequities, improving, and also we look for things that are needed, like improving communities and transforming our healthcare and public health systems, among other systems in this U.S. I wanted to quickly draw your eye to the critical role that CHWs play in advancing health equity. I know Jeff will also touch on this later, but by design, the CHW scope of practice, our competencies, our core roles and functions are really connected to advancing health equity. On multiple levels, CHW address the needs of clients and communities and systems by improving population health literacy, and that's working with individuals or groups in community or clinical settings, improving access to culturally and linguistically appropriate care and services in multiple settings, outreach, enrollment, and retention in appropriate care and services, including but not limited to health insurance programs, some of the new transformations like patient-centered medical homes, health homes, etc. We also, scope of practice includes identifying and addressing barriers to preventive and wellness care and services. CHWs help build individual, community, and systems capacity to actually eliminate health disparities and achieve health equity. They do this in partnership with community members, other providers, policymakers, and many other stakeholders. Next, you already heard from Monica earlier, but I wanted to illustrate, and I never want to do a presentation about CHWs without offering a nationally developed CHW definition that was provided by the APHA CHW section. The CHW section led efforts starting back in 2006 to develop a nationally recognized CHW definition and also to create a federal job classification code. This led to the development and submission of a proposed national CHW definition to the Bureau of Labor Statistics to develop a standard occupational code, and this occurred back in 2009. In 2010, those efforts were successful in creating CHW Standard Occupational Code 21-1094. And I will say that there were many people who contributed. Over 1,000 comments were provided at that time related to creating this, this code. Thank you. Part 2 of the definition, if you look at the bolded areas, it's basically part of the functional words that are used in the definition, and these are key words that we felt were important to be in that definition. On the next slide, that's the last portion of the definition, and it also, there's a note really about the fact that although, unfortunately, the definition that we submitted was not used for the current standard occupational code, although it is used verbatim for the federal CHW apprenticeship program. Many of you are aware and took action in current efforts led by the CHW section to amend the CHW definition on the occupational code by submitting letters and comments. I thank all of you. That effort was led by the APHA CHW section once again, and July 21st is when those comments closed. So we're looking forward to hearing more about those efforts. I now want to shift to our New England RHEC work plan goal that's related to CHWs, which is to leverage CHW organizing efforts in New England, including CHW training and credentialing efforts, by assisting in development and dissemination of materials detailing the role of CHWs in achieving health equity and reducing health disparities. Some of the strategies and action steps under this goal include supporting CHW workforce development and sustainability efforts in each state in New England by highlighting that CHW role in achieving health equity, as well as by some of the things I mentioned earlier around disseminating information and supporting data. These materials would help inform the dialogue as each New England state continues their efforts around CHW workforce development. We also one of the strategies is supporting the New England Community Health Worker Coalition, its organizing and leadership efforts across New England. You'll hear more about the regional coalition later from Lisa Renee. The RHEC embraces the guiding principles of CHW leadership and self-determination in defining the CHW workforce. And this made it important for our RHEC to be directly connected to CHW networks and associations in each state, as well as to the regional coalition. Currently, Barbara from Maine, myself from Massachusetts, and Danny Ritchie from Rhode Island are appointed RHEC members who are active in our state, local, and in our regional CHW networks and associations. I also want to illustrate and demonstrate that CHWs, by design, address social determinants of health. You guys have seen many charts related to the social determinants of health. We all know health isn't just about health care. It's about the social factors that contribute to achieving good health outcomes. Understanding the determinants of health is critical for devising strong public policy and action to promote health equity and the elimination of health disparities. The World Health Organization states that a person's health is shaped by conditions in which they are born, grow, live, work, and age, including the health system. It also is dependent on distribution of resources as well. Social determinants include but are not limited to housing, education, environment, jobs, transportation, food security, and of course health care. Here's another model that many of us have seen and used in the past around the determinants of health. And I want to use this to kind of give a crosswalk of how in New England the CHW core roles and competencies address the social determinants of health for our clients where they live, work, learn, and play. Some of the core competencies include outreach methods and strategies, where CHWs develop effective strategies and tools to reach different populations and communities and to engage them in real and equitable ways in their own health destiny. Client and community assessment, where CHWs who have always understood that place matters can effectively assess physical environments, living conditions, employment and work conditions, and social support networks as we develop solutions with our clients to the things that ail them. Cultural responsiveness and mediation is one of those key core competencies for CHWs, where we are providing culturally and linguistically appropriate services, serving as a bridge and cultural mediator in a bidirectional way between clients, communities, providers, policymakers, and systems, and vice versa. We also, one of the core competencies includes educating to promote healthy behavior change. And this is where CHWs are addressing personal and health practices and coping skills by providing health and wellness-related education and other opportunities to support healthy behavior change, even in conditions that don't foster an environment for these healthiest of choices, e.g. food deserts, not having areas safe to walk, exercise, economic vibrancy, etc. Also reduction of stress and stressors in life. Also, a very key component to our CHW core roles and competencies includes advocacy and community capacity building, where we address expressed needs of clients and communities and involve health, public health, human service, public safety, and others to address those needs. This is a very busy slide, and you can get more information on this from the NPA and also any of the RHEC websites, but this is really our blueprint for action under the NPA. And I wanted to also do a crosswalk to illustrate how CHW roles and competencies, just as they're aligned with addressing social determinants of health, they're also aligned with many of the goals and strategies within the National Partnership for Action, including Goal 1 around awareness, increasing awareness around health disparities, their impact on the nation, etc., where under strategies 1 and 2, informing a healthcare agenda that addresses the needs of clients and communities we serve is a role CHWs play, as well as developing and enhancing community provider partnerships, which is strategy 2 under Goal 1. And then strategy 3 around communication is something particularly related to providing culturally and linguistically appropriate messages, materials, and communications that CHWs are well versed in. Also under Goal 2, leadership, around strengthening and broadening leadership to address health disparities. CHWs do this by focusing on strategy 5, which is where we provide leadership around community and systems capacity building. And then Goal 3, we address around health systems and life experiences, basically by addressing strategy 11, which is around health communications. And of course, Goal 4, around cultural and linguistic competency, is really what our workforce is built for, around workforce that is culturally competent, reflects the rainbow of the cultures we serve, as well as the diversity inherent within the CHW workforce. Next, this is just another diagram that really, as I wind down, I just want to illustrate that speaks really to the importance of addressing health and wellness at multiple levels in order to achieve health equity. Although much of our time and resources are spent in the medical care and in the smaller circle on this diagram, we must shift more efforts and resources outside of medical care and even outside of the health services, the health sector, in order to truly address the determinants of health and achieve health equity for all. CHWs are well positioned to be the bridge and to help lead these efforts. In closing, I want to say that it's really critical at this time of activity throughout this country around CHWs to partner with CHW networks and associations, and also to develop and disseminate more data related to the role CHW play in eliminating health disparities. I ask you to partner with, when possible, the RHEC in your region and support some ongoing efforts and to enhance some new efforts to support CHWs, particularly to our role in addressing the determinants of health. Please ensure that CHWs, including those who may be outside of the healthcare system, are seen as valued partners and integrated into the CHW workforce development and sustainability efforts in each state. Please note, many of us have talked about this in the past, but the H in CHW really is for holistic public health, wellness, etc. And at this critical time of public health and healthcare transformation, we need to support equitable partnerships with the CHW workforce in each state and each region and embrace the principle of CHW leadership and CHW workforce self-determination, also known as Kuji Jakalia to those who are familiar with the Nguza Saba, the principles of Kwanzaa. This is my contact information. I thank you all for listening. I now want to turn it over to the wonderful, marvelous Lisa Renee Holderby Fox.
Thank you, Durrell. Good afternoon. I'd like to start by saying that I'll be sharing an experience. It's not a how-to. I don't think that you can take what I'm going to say and replicate it exactly, nor should you, in your regions. But what I'm hoping is that folks will be able to take nuggets and do something really innovative in their regions. I'd like to thank the Region 1 RHEC, OMH, and ASTHO for the invitation to share our experience with all of you today. I thought I would start by sharing the landscape, a little bit of the landscape for CHWs in Region 1. New England's like other regions of the country, and we're seeking creative and innovative ideas to promote health equity. Also, like other regions, CHWs are being embraced as partners in many of these efforts. There are approximately 8,600 CHWs in Region 1, and I'll show you a breakdown by state in just a moment. I want you to know that each state is supporting CHW activities, although they may be doing that in different capacities. And as you all know, funding has always been an issue, unfortunately, for the CHW workforce. And so that's one of the things that people are really trying to figure out here, just like they are across the country. And in addition to financing CHWs, many states are also investing in education and training, and in some cases, credentialing of the workforce. And then finally, like other regions, there are increasing numbers of statewide CHW associations, with Massachusetts being the first, followed by Rhode Island and Connecticut. I'm going to go back to the past slide for just a moment. These are the numbers that I was talking about in New England. So the numbers to the left are numbers that were cited in the HRSA National Workforce Study in 2007. And I was fortunate enough to be part of the team working on that report. And although these are some numbers to begin with, the whole team believed that the numbers were low. However, this being the first time that a national scan of CHWs where numbers were published, we were very excited. The numbers to the right are more recently updated by Massachusetts and Rhode Island. As you can see, the Massachusetts numbers are consistent, while Rhode Island is very different. I know both states continue to gather information and update the numbers as appropriate. Okay, so Region 1. I want you to know, just as Durrell mentioned, that all 6 states in New England are part of Region 1. Although we're a small region, we can drive it in several hours, tip to tip. We still have many health inequities within the region. Because of the size of the region, it's really prime for cross-state collaborations and partnerships. And I understand that many of the other regions across the country aren't necessarily as small or as easy to get to one part of the region to the next. So we're very fortunate in this aspect. And like the other regions, we have an RHEC and a Regional Health and Human Service Office. So many efforts today are a result of past work. In the past, seeds were planted for future collaborations, partnerships, and work, and I feel as though I would be remiss if I did not spend a moment talking about the New England Regional Minority Coalition. Several years ago, the New England Regional Minority Health Coalition came together, and they came together for many years. And although the group no longer formally exists, for over 10 years they met and hosted a biannual Health Disparities Conference. The group was comprised of state health departments, community and faith-based organizations, health plans, federal representation, and other stakeholders. This effort was supported by the Office of Minority Health, Region 1, and staff from that office participated in meetings since inception. I wanted to give you this background to demonstrate our past efforts, but also to remind you that our region was prime to really expand upon regional efforts. And although our prior regional efforts in Region 1, excuse me, also through prior regional efforts in Region 1, we were able to develop some personal relationships, in particular with OMH Region 1 and retired Admiral Mike Milner. For many years, Mike Milner and I had been discussing the potential for a regional effort to enhance public health efforts while highlighting the CHW workforce. In 2011, a small pocket of funding became available through OMH, and the Massachusetts Association of Community Health Workers was funded through this window of opportunity to host a regional CHW summit. So what I want to tell you about the CHW Summit is that it was really designed to foster regional collaboration to promote health equity, to develop a common understanding of the CHW workforce, strengthen the public health system's capacity to reach, engage, and provide quality health care and support services to underserved communities by institutionalizing CHWs, and then finally to enhance the collaboration amongst established and emerging CHW organizations and others throughout New England. These were the objectives, and as you can see, they were really focused on fostering and enhancing regional collaboration and promoting CHWs as partners in health equity work. One of the methods to ensure appropriate CHW workforce needs would be met in the design and implementation of the summit. CHWs were and continue to be engaged and provide leadership to this effort. Once funded, a planning committee was developed. Members included representation from all 6 states, a mix of CHWs and other stakeholders, including Jessica Cates from the Office of the Assistant Secretary of Health and Human Services. CHWs were also included in the list of summit presenters and led discussions. And I'll talk more about this in a moment, but CHWs are also engaged in leading the effort for the New England CHW Coalition as a result of the summit. The summit, I'd like to tell you a little bit more about the summit. The summit was a day and a half, and it was held in Manchester, New Hampshire, which is approximately a midway point for folks coming from all over New England. There were 50 participants, and the breakdown is shown here. 39% were CHWs, 16% state and local health departments, 14% federal agencies, 10% were employers, 8% education and training entities, and 6% each of funders and CHW Association staff. Approximately 5 participants from each state plus federal agencies. Several invitees were also members of the RHEC. Let me just say that we had developed, we had limited funding, and we developed a 50-person invite list for the first round of invitees, and then we also had a secondary list, which really included people that we would have loved to include in the primary list, but because funding was limited, that was very difficult. Let me say that no one refused the first round of invitations. And when I say no one, I'm talking about we had responses, positive responses from health commissioners across the region. Many of them sent their designees if they could not attend. And so we're really, really excited. And in the end, we had 50 participants participate. The first day included presentations from all 6 states regarding their current efforts around health equity and CHWs. We had a national landscape presentation of CHW efforts happening across the nation. The Massachusetts Department of Public Health shared its efforts to integrate and support CHWs from a state health department perspective, and the first day closed with Region 1 HHS Director Chris Hager discussing the ACA and opportunities to promote health equity and integrate CHWs in the work. Day 2, the participants led the work by identifying opportunities, discussing challenges, identifying who was missing from the discussion, and of course, next steps. So I want to say the summit was a huge success, and I'd like to share some of the outcomes from that. The first outcome was something called compromisos. The summit closed with everyone making a compromiso. A compromiso is a promise or a commitment. And let me just say that folks who participated have really tried to keep those compromisos. I still get stopped often by people who participated in the summit letting me know that they've either completed what they promised to do or they're still working towards completion, and many compromisos are ongoing. And examples of the compromisos were, I'm going to go back to my state and I'm going to share this information, or I'm going to get really involved in my statewide association, or I want to get to know the regional office much better. And so that was very exciting. Another outcome was the development of the New England CHW Coalition. Participants really decided that they did not want the conversation to end at the close of the summit. They wanted to continue to have those conversations. And although this effort is currently unfunded, MACHWA is donating staff time, and the coalition meets by phone every other month. And they've also been able to pull together coalition responses to regional issues affecting CHWs. More cross-state work is happening. And, I also have to say that if I didn't mention ongoing in-kind support from Region 1, and in particular Betsy Rosenfeld and Jessica Cates from OASH, I'd be extremely remiss. And in fact, they facilitated a call with Dr. Nadine Gracia so that we could share some of the work that was happening here in New England. And then finally, a few recommendations that I'd like to share and lessons learned. I've kind of combined them. And really to engage CHWs in all facets of CHW initiatives and programming. And as Durrell said earlier, we're really all collectively working on CHW leadership development. I'm going to ask everyone to support CHW organizations and networks, and whether that be through in-kind support, financial, or any other support you can offer on these organizations is crucial in order for them to succeed and be successful. Collaborate on all levels. The summit has really taught me, and I'm sure others in the room, that people are just eager to collaborate with each other, get to know what's happening in the states next to you. Really, I want to encourage everybody on the phone, and I'm going to ask you to encourage others who aren't on the phone, to really utilize your regional HHS offices. Staff is amazing there, and they're really, really willing to take the time to help you with issues to be successful, to eliminate health disparities and promote equity throughout the country. And I would just say, if you're going to try to host a summit or a similar type of meeting, ask your participants for a commitment and ask them to follow through with that. And then the final thing that I'd like to say is just, it's really important to build relationships over time. And one of the reasons that we want to do this is because we're never sure when those windows of opportunities are going to open up. And I'm sure that we've all been in situations where we're trying very quickly to put together collaborations, and many times those aren't successful. It's really important to build those relationships over time. Thank you. I know that I just gave a lot of information in a very short period of time, but my contact information is listed there, and I'm happy to have further discussions with anyone if they're interested. And so with that, I would like to hand this over to Jeff Wilkinson, who is not only a wonderful CHW supporter, ally, advocate, but he's also been a wonderful mentor to many CHWs here in Massachusetts. And so thank you for that, Jeff, and the floor is yours.
Thank you very much, Lisa Renee. I really appreciate that introduction and all the leadership that you've provided. Before I offer my remarks, we're going to take another polling question. And so we invite people to address the question, are there opportunities for CHWs to make a difference in addressing health disparities within your community? Please answer yes, no, or don't know. Click one of the answers, and we'll see the results as we're watching together. I'm just going to take a second to let these post, but looks like people are doing it pretty quickly. And we're also getting an overwhelming response. Obviously, people have drunk this Kool-Aid. Durrell and Lisa Renee have been persuasive, and you're already doing this kind of work in your communities. Okay, we're kind of the response rate is creeping forward a little bit. We've got 90% roughly answering yes, and I don't know, just under 10% of the responses. Should we let this complete itself totally, or I think we probably can move on. Those numbers are holding steady, so I think I'll move on and talk about the work of one health department. As Monica said at the outset, I've just within the last 3 weeks left the Department of Public Health in Massachusetts, so I'm talking about work that we did there. This is not an academic perspective yet. I also recognize that this is a statewide call, and so before talking about how a state health department can support community health workers, I want to address the 11% or so of people who answered at the outset that this was not a focus of work, these partnerships, because I don't want to assume that people understand why it's so important to use community health workers from a state health department perspective in addressing health equity and in other goals. So let me just say why Massachusetts has made this such a priority, and we're really compressing about 20 years into 15 minutes here. There's a long-standing history of that kind of long-term relationship building that Lisa Renee was talking about. First and foremost, nowadays, CHWs are really critical in addressing healthcare reform objectives and the triple aim of healthcare reform, and they are referenced specifically in the Federal Affordable Care Act as well as in our own healthcare reform law here in Massachusetts. There's a lot of sophisticated research documenting the effectiveness of CHWs in several domains. I'm going to summarize that briefly. And they're critically valuable in promoting health equity and addressing health disparities. They really serve as a bridge between clinical care and community prevention. And of course, for those of us in public health, that is the central challenge of healthcare reform. How do we link our efforts to prevent injury and disease with efforts that are fundamental to healthcare reform to improve integration of care and improve health outcomes and reduce costs, improve quality? It's important for community prevention not to get left out or poorly addressed, and CHWs are incredibly effective at that. There are four real important domains for CHW impact. I'm going to very briefly address them. They increase access to medical insurance, but also to the use of preventive services. They can increase access to non-urgent care, and as Durrell said, primary care and emerging models of care, patient-centered medical homes. And we think that they're going to have a very critical role in the success of affordable or accountable care organizations under health care reform. They are documented effective with vulnerable populations. And I won't read all of the populations. I'll trust that you can look at this slide. But CHWs are notably effective with the so-called high-risk, high-cost patients that are the focus of a lot of healthcare reform initiatives and innovations now. And they are addressing health disparities. And in Massachusetts, unfortunately, while we're a recognized leader in providing health services, we have documented disparities in these and other areas. And so we are like the rest of the country in this respect, and we need innovations. We need a workforce that's singularly effective at reaching the most vulnerable folks, typically because they come from those communities that they serve. CHWs have documented impact on the quality of health services, notably in chronic disease management, which of course is another, I think, probably universal priority for health departments around the country, and health department collaborations with health provider systems. They help improve the outcomes for care teams, where they're increasingly being integrated in patient self-management and compliance with prescription drugs and other kinds of physician orders. They help strengthen patient literacy, and they also help strengthen provider literacy and competence. And so, as a bridge, that is one of their most important contributions. And they have their increasing body of evidence, rigorous return on investment research showing that CHWs in various kinds of care collaborations have impact on reducing costs for various chronic diseases and for ER utilization. So if you weren't already sold on the importance of your health department promoting CHWs, I hope that provides some useful context. We think that CHWs deserve the moon and stars, but unfortunately they're a poorly supported workforce. They tend to have marginal pay and benefits. They tend to be funded on soft money, grant money. They tend to have spotty supervision and workforce development, career ladder opportunities. And so a lot of the work of the State Health Department of Massachusetts has been to promote workforce development as well as effective utilization of CHWs. And we've done this guided by something that Durrell Fox presented earlier, said, nothing about us without us. And it really comes out of a community empowerment philosophy. And you've heard recommendations from Durrell and Lisa Renee, and I will end up repeating that it's really critical in whatever you do at the State Health Department to involve CHWs directly in the process and in the thinking up front about what you're doing, why, and how. In Massachusetts, there are 5 general areas of support that we've provided to community health workers. And I just want to give you a few examples in each of these areas. The first, leadership, it has been a public priority of health commissioners over the last couple of administrations to support community health workers. And the current Commissioner of Public Health in Massachusetts, Cheryl Bartlett, is equally committed as her predecessor, John Auerbach, in supporting this workforce. And as in all things, public support from the public health leader really helps focus public attention and policy and program development. We've also supported the development of a state-based community health worker association. And we're fortunate in Massachusetts to have a real leader in this field, Gail Hirsch, who I believe is on the call, and I hope we could empower her to answer questions if appropriate. But for some 20 years, she's been a national leader at the State Health Department, directing the Office of Community Health Workers and helping and even serving as a founding member of the board of the Mass Association of Community Health Workers. That provides a voice for CHWs to speak as a workforce directly, so that, there's nothing about us without us. And there's a lot that state health departments can do to support CHW associations. We've committed a lot of DPH staff and resources, including that office and Gail's work and others. When I was a member of the commissioner's team, leadership on CHW issues out of the commissioner's office was a key area of responsibility. And so you can think about making that part of the portfolio responsibilities of senior people in your health department. There's been a lot of work on fundraising support, promotion of funding opportunities, demonstration grants for CHWs, and Massachusetts has integrated them into the SIM grant, the federal SIM grant that we won here. They're part of some CMMI funding. They're involved in Medicaid waiver. We're looking at CHW's roles as we think about submitting a state plan amendment for Medicaid to take advantage of the ruling by CMS last year that Medicaid can reimburse for preventive services that may be ordered by a clinical provider but not necessarily provided by a licensed provider. That opens a huge window for utilizing CHWs. And in a number of policy development areas, I'll summarize in a couple of minutes examples of that. Our state health department is probably the largest employer of CHWs through its contracts, and we use them in everything ranging from lead paint poisoning prevention to HIV/AIDS, immigrant and refugee services, chronic disease control, nutrition services, maternal and child health, and other areas. We've done a lot of training and curriculum development, including some innovative hybrid online and in-person training for CHWs, and also supporting private entities that provide training in the core competencies for CHWs. That's actually quite a significant priority for the health department, help build that infrastructure. We've done a lot of work on research, publications, partnering with private organizations, including the state-affiliated American Public Health Association, but also anti-poverty agencies, community colleges, and others. And so I think that's an important role for the state health department as convener and facilitator to be thinking about where are the strategic opportunities, workforce investment boards, et cetera. And then convening specific initiatives, which may involve the development of programs, funding of programs and services, but also policy initiatives. And through Gail's work particularly, but through others, the State Health Department has supported national networking and promotion of the CHW movement that Durrell summarized, and that has led to that Department of Labor classification that led to some of the successful work in the American Public Health Association. State Health Department can be a valuable partner in that kind of work. So we've had roles in inserting language about CHWs and services they provide and disparities reduction in two significant state healthcare reform laws. We've done workforce assessments, and if you haven't done a lot of that, this work, if you don't have a 20-year history, but you've got a solid current commitment, doing a workforce assessment may be a valuable way to start to involve numerous parties and get a handle on what the workforce is, what their needs are, what the opportunities for integration into healthcare reform may be. We did a major report with recommendations as a result of a clause in a state healthcare reform law that led to one of the nation's first state-based initiatives to credential this workforce. And we have a Massachusetts Board of Certification of Community Health Workers that is developing a program that will operate under the auspices of the State Health Department to provide a certification. It is based on a clear definition of scope of practice and core competencies for CHWs. It will also include standards for training programs that prepare CHWs for presumptive eligibility for certification. And we're looking at all sorts of issues, including continuing ed, renewals of certificates, reciprocity with other states, et cetera. It's important because there was a strong consensus when we did our state workforce assessment and looking at workforce development recommendations. And I should say that was a process that involved about 40 stakeholders from all sectors. It was very interesting that payers of health provider services, and the insurance companies, providers themselves, and CHWs had a united, strong consensus about the importance of credentialing and certification as a voluntary measure. So we have taken that forward, and we think that it will provide a kind of standard of quality on which payers and providers can depend, and provide workforce opportunities for CHWs. And it will probably be critical as we think about moving forward with the possibility of a state plan amendment for Medicaid. So I have recommendations that are quite parallel to those you've already heard. It's very valuable and important for state health departments to support state community health worker associations. There's no substitute for having CHWs at the table in thinking about whatever work you may be doing. And it's disconcerting how easy it is for well-intentioned professionals, and I've been at these tables, to find ourselves sitting there talking about CHWs without CHWs in the room. And we can't succeed without the CHW voice. So engage CHWs directly in whatever kind of policy, program, and funding development you do. Coordinate your programs within your state health departments. And this is challenging because we often operate in silos within our state health departments, and this is an opportunity because of the wide array of areas in which CHWs are effective to disperse funding and policy throughout our organizations. And so creating some structure to talk about who's doing what, who's already using CHWs, and how to coordinate policy and program, I think it can be very productive. I think it will also be very useful as health departments interact increasingly with health care providers looking at implementation of health care reform. What would be the role, for instance, of CHWs working with hospitals in community health needs assessments and in doing those assessments, adding a community voice, and then planning services. So it's important to collaborate with external partners and be prepared. You're going to need to commit some resources to do this. Some of them may be in kind, using staff that you have, but some of them will involve reallocation of available contract dollars and other funds that you may raise, or grants that you may seek or work with other partners to seek. This is such a productive area of work that I think it bears some creative thinking about how to do it. And finally, I would caution that we avoid the unintended consequences of professionalization of this workforce. And there's a very robust national discussion about how to avoid turning CHWs into such a professionalized workforce that they lose that which is most special about and for them, that deep connection to community, that somewhat intangible sense of trust and connection that is the heart of why they're important. So as we bring them to the table, bring CHWs to the table, I think it behooves those of us who work for state health departments to approach this whole subject with a great deal of humility and appreciation. And with that, I'm going to thank you very much for the opportunity to participate. Thank ASTHO and the Office of Minority Health, and turn this over to Barbara Ginley.
Great. Thanks, Jeff. I would like to acknowledge the previous speakers. I have the good fortune of following Durrell, Lisa Renee, and Jeff, who, from my perspective, and I'm sure listeners will agree, really bring so much expertise and experience to the topic that we're discussing today. And I think, as you'll hear from me as the quote-unquote somewhat new kid on the block, I have really looked for those opportunities to take advantage of the lessons learned by others, to really align myself with the work that's going on regionally, because I feel as though what's gone on regionally in so many different ways can help us build a strong system here in Maine to support community health workers. I also would like to acknowledge our federal partners who made this afternoon possible, and thank all of you listeners for joining us on behalf of the Region 1 RHEC. My presentation is going to be slightly different in that I'm really going to take parts of each of what Durrell, Lisa, Renee, and Jeff shared and talk about how, again, the regional collaboration, the work that's gone on at the Region 1 RHEC, and then the partner states work, how that's really helped inform what we're doing here in Maine. And I feel like it's important to bring that perspective because it can be somewhat daunting, I know from my personal experience, to think about states like Massachusetts and Minnesota and Texas who've been really engaging community health workers for a number of years and being very thoughtful and purposeful about setting in motion the systems to support the workforce to feel like you may be coming late to the game. So I'm here to tell you that it is possible to start and to be moving forward on supporting community health workers in your own state, despite of when you're starting on that venture. The one thing I did want to start with, I know Jeff made mention of the opportunities under ACA as it relates to potential reimbursement for preventive services. The monograph that I reference here also speaks to other opportunities and incentives under ACA to support community health workers, both with the Health Homes Initiative, which looks at supporting states with enhanced payments for providing care through multidisciplinary teams for specific core services. And some states have really operationalized that in a way where they name community health workers as part of those teams, and there's plenty of opportunity for the CHWs to be providing those core services right in line with the APHA definition on issues like family support, making referrals, assisting with transitions in care, being that bridge. The perspective that I'm going to bring today is from a state that was funded by the innovation program within CMS to develop a statewide innovation model to test the development of a model that would transform our healthcare system. This graphic gives you a sense of how Maine as a state set out to do this work. As you can see, developing a community health worker initiative appears under our workforce development pillar of primary innovation. And that's not to say that we don't touch upon the others as it relates to payment reform, as it relates to engaging patients and or communities or strengthening primary care. But at the core, we realized that if we wanted to come out at the other end of this project, which is 36 months, that we really had to have a focus on building a system and infrastructure to support the workforce. The Community Health Worker Initiative in Maine is a partnership project. It involves not only the agency that I work for, the Maine Migrant Health Program, but our state health department, the Maine CDC, as well as medical care development. Now those are just the partners for the Community Health Worker Initiative component of CIM. Under CIM, 3 goals were set out for the Community Health Worker Initiative. It's a little bit of a misnomer to say to develop a new healthcare profession. There were certainly community health workers working in Maine prior to this project launching in 2013. But I think the important part of the first goal is the recognition piece, is the promoting the identity and the role that CHWs could play in a new healthcare landscape. We are hard at work at getting 4 pilot projects up off the ground. Our hope is that by expanding capacity, we are in fact developing new community health workers to be out in communities providing care and services, perhaps in parts of our state where there was no CHW capacity. And certainly the work that will lead to sustainability are these latter 2 pieces of making sure that we have a system in place to train and certify or register community health workers, which of course we will need as it relates to developing any sort of financial models to support more long-term incorporation or integration of CHWs into our system of care. Now, as I said when I introduced myself, much of my work has been informed by the work of others, and I thought probably the easiest way for me to speak to that was by sharing with you our timeline for year 1. We're actually coming up on the end of year 1 this September. And when I stepped into this role and was given the work plan and given the grant narrative for the federal proposal, there were so many places where I saw, again, that the work of others could really help us inform what we do here in Maine. Just by way of example, in terms of completing our background information gathering, doing an environmental scan, one of the first things that I did was to conduct key informant interviews with other states on how they went about building a system to support community health workers. And clearly, from my perspective, there were folks outside of our region to connect with, but I also knew from having attended the summit that Lisa Renee spoke about that it would be really important for me to connect with the folks in Connecticut at their AHEC to learn about what role their AHEC had played in helping to support the training and education of community health workers. I knew that under the Vermont Blueprint for Health that CHWs had been adopted into community care teams to be providing services and bridging between providers and communities. And I certainly knew that the folks both at Matchwa and within the Mass Department of Health could really help provide me with recommendations on how do you institutionalize the integration of CHWs within public health programming. If you're going to begin to do grant making or issue an RFP that promotes the use of community health workers, what should that look like as it may relate to training, as it may relate to supervision? So those are just a handful examples of where the coalition and those contacts and those relationships were really key to the work that we've done here in Maine. Sorry, my computer timed out. And I will also say one of those, critical learnings for me personally, and I will be echoing much of what Jeff, Lisa Renee, and Durrell shared, is that leadership component, that engagement in a really meaningful and transparent way of community health workers to be involved in what we were trying to do here in Maine, recognizing, as Lisa Renee said, that you need to have strong relationships in place when opportunity presents itself. So when the project started, initially the timeline looked as though we wouldn't begin talking about making recommendations for sustainability until year 3, and that the real work initially would focus on building up the opportunity to fund these pilot projects. And I really asked our state health agency as well as our other partner, MCD, that we rethink that and that we look to build that capacity, that level of engagement early on in the process. It's not as though that we had a mandate to establish an association, but I knew from learning from others that having that network in place would be critical, not only in terms of making sure that what we developed would actually not only serve the policymakers well, but actually serve community health workers, but also that we would need to have those relationships in place for after the project was completed. So we have convened what we're referring to as our stakeholder group. It's something that we started in October of last year, and we did so with, it's an open door. Anyone who wishes to be sitting at the table and working with us on developing those, what I call almost building stones, or doing the foundational work, anyone's welcome to join in doing that. Having said that, I early on have also made sure that we're going the extra mile in terms of figuring out ways to make sure CHWs can participate, and whether that's saying we need to secure funding to help pay stipends or reimburse for transportation, or if it means that I'm taking what we're working on to places where community health workers are already meeting, already working, then those are the pieces that we're figuring into how we do this work. So I said to the folks who came to the table and said, what do we want of this, from this process? How do we want to move this forward? And these are, in thinking back on those first few months, this is generally our roadmap to say these are the things that we hope to achieve. This is what we'd like to see come out of this 36-month project. Now, remember, this is one of many pieces of SIM, and I'm particularly proud that we're able to do this engagement piece and to be moving this forward in a way that I hope will serve, again, our state well from a very broad perspective. That system building piece you can clearly see in this slide as it relates to workforce development, as it relates to discussion and development of reimbursement and payment models, and thinking too on future project design and making sure that when we're doing the pilots that the evaluation really helps inform future work here in Maine and elsewhere. But it was also important that we develop a common language. We realized that when you say community health worker, that may mean a different thing depending on the audience. We also realized because there's not broad adoption of CHWs in our state, that there was clear need for doing some education and awareness on professional identity, especially as it related to primary care medical homes, our CCTs, which are our Medicaid health homes, and really looking to engage folks who might have overlooked community health workers as a key player to their team. And again, thinking back on the focus of our discussion on thinking about the role a community health worker could play in addressing disparities and also in moving on health equity. I'm actually going to close not with recommendations, but I'm going to bring us full circle because I think it's an example of some work, that foundational work that we've done but I think it's also hits home how we here in Maine have tried to be mindful about the community health workers' role in health equity. And as I said, and as you can see from this list of commitments, one of the things that we worked on early on was to begin to develop common language. And we started with developing a community health worker definition to ground our work and have built on that. We've moved from this to developing and adopting core roles and responsibilities, to developing and adopting a crosswalk of skills and core competencies to inform training. But it really all comes back to a common definition. And this definition, I know if for those of you who are familiar with the APHA definition, you'll hear bits and pieces of it. We looked at APHAs, we looked at the World Health Organizations, we looked at a number of other states, but we wanted to operationalize it for ourselves and for it to help guide the work that we were doing, not only developmentally, but also as it might relate to policy development. And in closing, the 2 points that I want to make as it relates to thinking about relationship of CHWs to health equity is thinking about the role of CHWs in terms of focusing their work on reducing disparities, promoting health, and thinking about that from promoting health for all, and also thinking in the advocacy piece. You know, Durrell started us off in terms of thinking about and talking about social determinants of health. From the work that we're trying to do, community health workers can play that critical role in giving voice to addressing and or recognizing barriers to health, to giving voice to naming what social determinants are actually impacting an individual's health, and then also in terms of really helping to build community capacity. And with that, I will close out my time, if I can get the slide to, and have provided you with my contact information at the Migrant Health Program, and I will hand it back over to Monica.
Thank you so much, Barbara, and thank you to Durrell, Lisa, Renee, Jeff, and Barbara for this really great presentation. I've been tracking the chat box in the lower left-hand corner. We've got a lot of questions, so operator, while we're queuing up the live Q&A, I'm going to go ahead and try to get through some of these chat box questions. One of the questions that came up was actually a question that I had for the speakers, and it's whether you have seen examples in the Region 1 states or in your conversations with other states where health insurance plans, community health centers, or other accountable care organizations where CHWs may work are actually receiving reimbursement for the services that they're offering to be part of these integrated health teams in these different settings. So I will ask that question, and if any of the presenters would like to respond, that would be great, and we'll continue to get folks lined up for the live Q&A.
Yeah, I mean, I think all of us were probably going to talk, and then none of us talked. But I know that there are examples and models around the country. When you look at the system that's in place in Minnesota that's been referenced a couple of times, you see a direct effort to get CHWs reimbursed through Medicaid. You've heard about some of the Medicaid waivers and other forms, but I also know that there have been community coalitions. There was a small model in the western part of Massachusetts where funding was pooled from revenues of multiple health centers. It's out in the Springfield area. and they were actually able to fund a generalist CHW that basically worked for this coalition of agencies and worked in the community. We also know there are published articles related to folks like Premier Plus, Health Plus, I think Christus Fund System down in Texas, and there's a few other examples where they've actually used operating budget from health plans and others to actually pay for the FTEs of CHWs out of revenues and operating costs versus grants.
And this is Lisa Renee, and I'd also like to add that although there are lots of windows of opportunities right now, and we're talking a lot about reimbursement, many of us feel pretty strongly that reimbursement is a part of the solution to pay for CHWs, and that we need to be very careful about putting all of our eggs in that one basket.
Thanks for pointing that out, Renee. Definitely reimbursement is one of those mechanisms that I think was a theme in your presentations, all four of your presentations in terms of sustainability, but definitely have to be aware of implications and sort of unintended consequences of just focusing only on that path or mechanism. Operator, do we have any live questions on the call?
Ladies and gentlemen, if you would like to register for a question, please press the 1 followed by the 4 on your telephone. You will hear a 3-tone prompt to acknowledge your request. If your question has been answered and you would like to withdraw your registration, please press the 1 followed by the 3. Once again, ladies and gentlemen, that is the 1-4 to register for a question.
Okay, while we're waiting, there is a question in the chat box from Jean Hutchins, and I'll read it for you all. There's several providers in Jean states who have employees that fit the definition of CHW but may have other titles, case managers, coordinators. Are those CHWs? Does it need to be a separate profession and identity? And I know that there's been a lot of work done on this in terms of how to define and different titles that might fit within it. So I will open that up to the presenters, and then following that response, we'll open up the line for the live Q&A.
Hi, it's Jeff Wilkinson. I actually posted an answer to Jean, but it looks like I was answering Jeffrey Waddy, but the answer briefly is yes. Our 2005 workforce assessment in Massachusetts and then subsequent assessments, and this is true around the country, have documented literally dozens of job titles that we understand to be community health workers. So it's an umbrella term. It's a broadly inclusive job classification, but it really has to do with who's doing the work and how they are relating to community. But you absolutely can have different job titles. And another theme that has emerged in the online chat that I want to just also emphasize in this regard is that CHWs work outside of the health sector proper. You have CHWs working in public safety, in housing, and in a variety of different areas, so that as Durrell was talking about, addressing social determinants of health, whether or not they actually work in the direct provision of health care or public health services. Most of them do, and all of them have valuable impact on health, but they may not be directly in the sector.
And what you will also notice that many states who have adopted CHW definitions will sometimes give you the common titles and terms. I think we listed over 55 in our state reports of titles commonly used for CHWs in our state, and I know others have done that as well.
And this is Lisa Renee. Our hope is that more and more employers and funders will embrace the CHW term, and we'll see more of that in proposals, et cetera, as we move forward.
Thank you. Operator, do we have any callers on the line with questions?
We have no questions at this time.
Why don't I go back to the chat box, because this is sort of linked to what you were all saying in terms of community health workers really going beyond just the public health and the healthcare sector and being able to bridge different sectors. One of the participants asked or referenced that one of our speakers mentioned that CHWs are poorly supported, and our state health department is trying to get more businesses involved, particularly health IT industry, for example, in terms of additional support to help facilitate CHWs and I suppose to provide that sustainability to their funding. Just curious if any of the presenters have a response to that idea.
Yes. Again, this is Jeff. I'm pausing so that if Durrell or Lisa Renee or Barbara want to jump in here, I'll hold off for a second. But since they're not jumping in, I will say that, yes, in a couple of respects. Certainly in the healthcare sector, there are efforts in Massachusetts and other states to engage health providers as employers, as businesses, in looking at compensation and benefits for CHWs and workforce development opportunities, and I think some of those are productive. We've also been doing some work more broadly with the workforce development sector. I mentioned worker investment boards, but there's a whole world of employment development and workforce development outside of health that is quite interested in CHWs as a workforce and for the business opportunities they may provide. Higher education, similarly, is looking at this, and since there's been a lot of productive work with community colleges along these lines, and some of them see the CHW field as a growth field, so they're training and educational opportunities and employment opportunities for their graduates. They're figuring and making investments. And I also think it's important to note that the philanthropic sector has been a leader for a number of years and continues to provide critical support, including studies and initiatives in this area, but also seed funding. Our Blue Cross Blue Shield Foundation in Massachusetts has made grants available to community health centers and is now doing some active partnering between providers who work with high-risk, high-care patients and larger provider systems that are looking at implementation of the Affordable Care Act.
Yeah, I'll also just note that there are also opportunities in justice. For instance, the Attorney General for Massachusetts was able to get some settlement dollars, and $600,000 of those settlement dollars went directly towards supporting CHWs in the central part of Massachusetts. And I also know Lisa Renee talked about building relationships, and there was a gentleman who used to work for HHS who actually went to IBM. And for several months, there were communications meetings that once he got in the door at IBM, he brought his health and public health hat and pulled CHWs in to communicate with them. I don't know if there's more workplace wellness discussions, but I think that's another opportunity for CHWs to get engaged in some of the non-traditional settings, particularly related to workplace wellness, helping people navigate, helping people have less time lost at work, etc.
And this is Barbara. I would say, one of the things that I've done with my work here in Maine is, as Jeff mentioned, the workforce investment boards, is really engage folks within our Department of Labor, folks who are working on apprenticeship programs, looking at what federal dollars may be flowing in to help long-term unemployed, and just creating that awareness. I think, at least in our state, there's quite a bit of awareness of what workforce needs we'll have as it relates to, say, 2025 and sharp reductions in number of nurses and physicians in our state, but really trying to broaden that dialogue so that folks begin to think, so yes, CHWs aren't, I'm not saying we'll step into the role of being a nurse or a physician, but are there are there roles for community health workers as we begin to look at workforce needs for our state moving forward? And quite frankly, thinking about career ladder, at least here in our state, one thing that is an active engagement between our community colleges and adult ed and philanthropy is really looking at how we can provide a career path potentially for folks who may be foreign trained physicians or clinicians to help them be able to be working at their original credential or potentially in some clinical role, but can they, as they work towards that, is there meaningful work for them as a community health worker where they may be using their skills and expertises in an interim way. So I do think it's important to perhaps engage folks that you may not necessarily consider as quote-unquote public health partners or part of the traditional healthcare system.
Thank you, Barbara. And I think that'll have to be the last word because we've reached the end of our webinar this afternoon. I know that, and we can tell from your presentations and your responses that there's a lot of commitment and passion in terms of the role of community health workers and their role in this sort of emerging landscape of health and more broadly using the social determinants framework. One thing I will mention is that participants and speakers may also want to look at the Federal Reserve Bank in your regions because there's a lot of work around social impact bonds, and I believe that some of the examples that they've collected have featured the use of community health workers in non-health settings, so please visit those websites. I want to thank everyone again for joining us this afternoon on the webinar. As we mentioned at the top of the call, you'll be directed to an evaluation as soon as we wrap up. It's really important for us to receive feedback from all of you on the webinar so that we can use it for planning future projects and webinars. Also wanted to put in a quick plug for the New England RHEX website. Again, that was on the last slide that Barbara shared with us so that you could get more information about how to join Region 1 and their efforts around health equity. Finally, I'd like to thank the Office of Minority Health again for sponsoring this webinar and to our speakers for their great presentations. A recording of the webinar along with the slide decks will be posted on the ASTHO website in the next few days along with responses to the Q&As and the questions that we weren't able to get to this afternoon. The web address should be on your screen now, and we hope that you'll use this as a resource and share the link with your other colleagues once it's available. Thanks again to the presenters and to all of our participants, and hope that you enjoy the rest of your day. Thank you.
Thank you.
Thank you. Thank you.